Hi, this is David Evans with AIDSmeds and PAWS. I'm here at the Conference on Retroviruses and Opportunistic Infections in San Francisco. With me is Mitchell Warren, who is the Executive Director of the AIDS Vaccine Advocacy Coalition in New York City. Welcome.
Great. Thanks very much.
Sure. So we're going to talk a little bit about HIV prevention and where we are with the field. Tony Fauci, who is the director of the National Institute of Allergy and Infectious Diseases at the National Institute of Health, gave a talk on the first day of the conference, just laying out where he sees the state of vaccine development and other kinds of prevention modalities. And I wonder, what are your impressions of where we are?
Well, Dr. Fauci's presentation did something I think really important. In addition to laying out kind of the state of the science, he put out a challenge really for all of us, which was something to the effect that we need to take some high risks and really put the bar very high for what we're trying to achieve in all of the research efforts. And I think it's a hell of a challenge, but it comes at a really great time. I think what he laid out and what really has come out in this conference is we're at a critical moment in prevention science. I mean, we have some tantalizing findings over the last few months, the last year really, that he summarized. And they all point in exciting directions, but I think it's safe to say we're not sure exactly which directions those are. So, for example, he talked about, rightly, the Thai vaccine result, and there was a presentation of the data yesterday. That was a huge finding from late last year, the first ever evidence in humans that a vaccine might work.
That was the RV144, is that right?
RV144. So this was the hugest prevention trial ever, 16,400 Thai men and women in this trial. And the result, as described by Dr. Fauci and in the presentation yesterday, reiterated the result, which was a very modest effect, maybe 30%, not a product that one would ever want to license at this point, but a finding nonetheless. What's interesting is we talk about these trials as test of concept trials, and we say, well, this successfully proved the concept, and it did tell us for the first time in a human trial that an AIDS vaccine can help to reduce the risk of HIV. The challenge we have now is we're not sure exactly what concept was proven there, because we don't entirely know why that vaccine had the effect that it did. So it's great to have the effect, and we need to build on that trial, and that's what has been a bit of a buzz around the conference this week. What do you do next? There's not a lot of clarity exactly of what to do next, and that is frustrating in many respects. After coming out of a large trial, you'd like to say, here's the roadmap ahead, and the roadmap's not as well constructed as we'd all like, but there is a very robust discussion happening, and I think over the next few months, I think the thing to watch is what does the scientific community and what do the funders of the scientific community decide as priorities for building on the results of RV144.
With another focus of his talk was the importance of looking at antiretrovirals, but for prevention. And I think that particularly with pre-exposure prophylaxis or PrEP, we've heard in the past presenters, very knowledgeable presenters, essentially say, I would be very surprised if this doesn't work. Okay, that gets people excited. There's going to be this prevention tool. But now we're hearing about all of these potential barriers to actually using it. And I wonder if you could describe a little bit about why it isn't so obvious that we can just roll this out.
Yeah, I think that and I'm not a scientist, but I actually share the enthusiasm and interest in the promise of potentially having antiretrovirals for prevention. And I think the biologic plausibility is there. We see a lot, and even this week presented some really exciting animal data that tell us that it is likely to work on a biomedical level. I think the important point in all of this, whether we talk about vaccines or topical microbicides now, which are based on antiretrovirals as well, or oral pre-exposure prophylaxis or test and treat, that they obviously have a key biomedical component. Those products are all biomedical, but the intervention is as much or more behavioral than it is biomedical. And I think we often lose sight of that. We think that the products are going to end the epidemic. Well, they don't. It's people using products that will end the epidemic. And it's basically when humans get involved, things get messy. So there are a whole range of reasons why, if PrEP were to work, and we'll begin to get answers over the next 12, 24 months from a number of exciting trials, both in PrEP, in topical microbicides with ARVs, and in test and treat. So the research pipeline is rich and exciting. But we already are now beginning to have lots of conversations with the researchers and with policymakers and with communities that say, wow, antiretroviral-based prevention has whole new issues that we haven't really thought about before. And if you think about prevention, historically, 28 years of it, safer sex, use condoms, clean needles, those are messages that, if we want to give out, and you can pretty much give it to anybody.
Right.
I think it's safe to say that antiretroviral-based prevention is going, if it works, it's going to be an entirely new paradigm of prevention. It's going to be one that inevitably has to be very targeted. We're going to need to know your status before you get involved in antiretrovirals for prevention. So if you're HIV negative, and if the trials work, PrEP may be a good thing, but you need to know your status on an ongoing basis. So do we have the infrastructure in the United States and certainly internationally to have people on frequent testing? So because if you're on antiretrovirals and you're negative and you do seroconvert, because none of these products are likely to be 100% effective, you need to know that because you don't want to be on that therapy. So there are issues of testing frequency. There are issues of certainly with oral PrEP. Who gets it? If oral PrEP works, and it's with tenofovir or tenofovir and FTC, who gets it? Someone who's HIV infected who needs that drug as the frontline medication? Or the person who's HIV negative, who may be protected from HIV because of taking this pill. And we're going to be at a point where we're going to have to look and see prioritization and funding realities. And so there's that issue. And then, of course, even if it works in the clinical trials are not real-life settings. So we deal with adherence. We deal, let's say it works in the clinical trial. Are people going to take it every day? Do people need to take it every day?
Right.
And do they take it for every day that they're at risk over a month, a year, for the rest of their lives? What does that mean for levels of drug toxicities? What does it mean for other drug-drug interactions? So there are, and none of these issues are ones that should tell us to stop exploring PrEP.
Right.
Because we do need to first and foremost, we need to answer the question, does PrEP work? Do antiretrovirals for prevention work? But if they do in the scientific setting, we then have a whole range of issues that we need to begin to ask and answer to see if we're actually ready to optimize the research result into public health impact. And there are a lot of questions we're going to have to be answering over the next several years.
One last question, throw a little bit of a curveball maybe, is I think condoms are a really interesting story, which is that socially, religiously, politically, so we have this thing that we know really, really works, and yet we have people who spread misinformation about it. We have governments or legislators who oppose paying for it because people are supposed to not have sex outside of marriage. Do you think we're going to have political opposition to PrEP if and when it becomes available?
If I've learned anything in my experience in the AIDS epidemic, it is that everything carries with it political, cultural, social dynamics. I'd be shocked if we didn't. And that's not just about PrEP. I think any intervention, at the end of the day, HIV is a disease that is transmitted sexually. It's transmitted through drug use. So any prevention tool is automatically going to have to deal with sex and drugs.
Right.
So whether it's clean needles, whether it's condoms, whether it's male circumcision, whether it's a vaccine. I mean, you could even draw the analogy. We've seen what happened when the HPV vaccine was first introduced just a few years ago, a vaccine for adolescent girls and recently adolescent boys to prevent HPV. We could end cervical cancer in the next generation with that vaccine made universally available. And what was the opposition? Oh, people are going to have more sex if they get the HPV vaccine. Right. So fill in the blank. People are going to have more sex if they get the condom, the PrEP, the male circumcision, the vaccine, the microbicide. And but it's again, it's one of those issues that we can anticipate having to deal with. None of those questions should be reasons not to push on, because that's the nature of activism and advocacy that has moved AIDS, the AIDS response to the point where it is, which has been incredibly successful in many places. But yeah, I think that I guess at the end of the day, as hard as all of this science is, and when I come to CROI, I'm always reminded of how complicated the science is. It's what comes after the science that's even harder. That even if all of these things that work or may work, proving them scientifically is easy. compared to optimizing them for public health impact. And that's what we need to be focusing on.
Great. Well, thank you so much for taking the time.
Thanks very much. Great to see you.